Dr. Sarah Thompson, a dedicated primary care physician, stared at the proposal with a furrowed brow. Her clinic, a cornerstone of the community for years, was considering a major shift, transitioning from a fee-for-service model to capitation. The idea filled her with unease. She had always prided herself on providing personalized care to each patient, spending as much time as needed to address their concerns. Capitation, with its fixed payments per patient, seemed to contradict her entire approach. Would she be pressured to rush consultations? Would the quality of care be compromised? Dr. Sarah was skeptical, to say the least. The weight of responsibility pressed down on her. She cared deeply for her patients and couldn't bear the thought of anything jeopardizing their well-being. Yet, she couldn't deny the growing financial strain on her practice. The current healthcare system, with its emphasis on volume over value, was taking its toll. Dr. Sarah knew something had to change, but was capitation the right answer? The essence of capitation, as Dr. Sarah understood it, was a fundamental shift in how healthcare providers were compensated. Instead of receiving payment for each service rendered, like an office visit, a test, or a procedure, they would receive a fixed amount per patient, regardless of the actual services used. This predetermined fee, known as a capitation rate, was designed to cover all the healthcare needs of a patient within a specific period. This new approach aimed to incentivize quality care and preventive measures. The fee-for-service model, on the other hand, often led to unnecessary tests and procedures. This was because doctors were financially rewarded for providing more services, even if they weren't always essential. This approach, while seemingly beneficial for providers in the short term, contributed to the escalating costs of healthcare without necessarily improving patient outcomes. Capitation, with its emphasis on keeping patients healthy and out of the hospital, seemed to offer a more sustainable solution.
Change is never easy, Sarah, especially when it comes to something as fundamental as how we care for our patients.
Eager to gain a clearer perspective, Dr. Sarah sought the advice of her colleague, Dr. Mike Evans, a seasoned physician who had experience with capitation models. Dr. Mike, known for his calm demeanor and insightful advice, listened patiently as Dr. Sarah voiced her concerns. He acknowledged her apprehensions, assuring her that her feelings were valid.
It's about shifting our focus from treating illness to preventing it.
Dr. Mike explained that while capitation came with its own set of challenges, it also presented an opportunity to practice medicine in a way that prioritized patient health and well-being over simply the number of patients seen. He emphasized the importance of strong patient relationships, open communication, and a proactive approach to care under this model. As Dr. Sarah delved deeper into the world of capitation, she discovered that it wasn't a one-size-fits-all approach. There were various models, each with its nuances and implications for healthcare providers. The most common ones, she learned, were global capitation, primary care capitation, and specialty capitation. Global capitation, as the name suggested, encompassed the most comprehensive range of services, covering everything from primary care to hospitalizations and specialty care. This model placed a significant amount of financial risk and responsibility on healthcare providers. Primary care capitation, on the other hand, focused specifically on primary care services, with patients assigned to a primary care physician, who acted as the gatekeeper for their healthcare needs. Specialty capitation, as one might expect, involved contracting with specialists for a defined set of services for a specific population. Each model came with its own set of complexities and considerations, and the choice of which to adopt depended on various factors, including the size and structure of the healthcare organization, the patient population, and the local healthcare market. Section 5. Delving deeper, partial versus full risk. Within the realm of capitation models, Dr. Sarah encountered another layer of complexity: partial capitation and full risk capitation. Partial capitation, she learned, involved sharing the financial risk between the payer, typically an insurance company or government program, and the healthcare provider. In this arrangement, the provider received a capitated payment for a defined set of services, but the payer still bore some of the financial responsibility for high-cost services or unexpected healthcare utilization. Full risk capitation, as the name implied, placed the entire financial risk on the healthcare provider. In this scenario, the provider received a fixed capitated payment per patient, and was responsible for covering all of the patient's healthcare costs, regardless of the actual utilization. While full-risk capitation offered the potential for higher financial rewards, it also came with a greater level of risk, as providers were fully exposed to the financial consequences of unexpected healthcare expenses. Section 6. Mr. Johnson and Anna, Two Sides of the Coin. As Dr. Sarah grappled with the intricacies of capitation, she couldn't help but think about her patients and how this new system would impact their lives. She thought about Mr. Johnson, a kind, elderly gentleman with a myriad of health problems. He was a frequent visitor to her clinic, requiring regular checkups, blood tests, and medication refills. Under a capitation model, would she have the same flexibility to spend time with him, addressing his concerns and ensuring his well-being? Then there was Anna, a young mother who struggled to afford healthy food for her family. Anna often delayed seeking medical attention due to financial constraints, leading to more serious health issues down the line. Could a capitation model, with its emphasis on preventive care, help someone like Anna access the care she needed before her problems escalated? Dr. Sarah realized that capitation was not just a matter of numbers and financial models, it was about real people's lives. Section 7. A shift in perspective. Dr. Sarah's initial skepticism gradually gave way to a more nuanced understanding as she immersed herself in the intricacies of capitation. She realized that while the model presented challenges, it also offered a unique opportunity to reshape the way healthcare was delivered. The traditional fee-for-service model, with its focus on volume rather than value, had created a system where patients were often treated as commodities rather than individuals with unique needs and circumstances. Capitation, on the other hand, had the potential to shift the emphasis from simply treating illness to promoting wellness and preventing disease. By aligning financial incentives with patient outcomes, capitation encouraged healthcare providers to adopt a more holistic and proactive approach to care. Section 8. Embracing a holistic approach. Dr. Sarah began to envision a future where healthcare was no longer a reactive system, scrambling to address problems after they arose, but a proactive force, empowering individuals to take control of their health and well-being. She saw the potential for capitation to foster stronger patient-doctor relationships built on trust, open communication, and shared decision-making. She realized that capitation could create an environment where doctors were rewarded for keeping their patients healthy, not just for treating them when they were sick. This shift in perspective, from treating illness to preventing it, resonated deeply with Dr. Sarah's core values as a physician. Section 9. The future of healthcare. Dr. Sarah began to see capitation not just as a payment model, but as a catalyst for transformative change in the healthcare landscape. She envisioned a future where technology played an increasingly important role in monitoring patient health, providing real-time data to healthcare providers and empowering individuals to take a more active role in managing their well-being. She imagined a world where artificial intelligence and machine learning were harnessed to analyze vast amounts of data, identifying patterns and trends that could help predict and prevent disease before it even manifested. Section 10. Capitation, a catalyst for change. Dr. Sarah realized that the success of capitation hinged on a fundamental shift in mindset, not just for healthcare providers, but for patients as well. It required a move away from the traditional passive model of healthcare, where patients simply followed doctors' orders, to a more collaborative and empowered approach, where patients were active participants in their own health journey. This meant embracing preventive care, adopting healthy lifestyle habits, and taking responsibility for one's own well-being. It meant viewing healthcare not as a series of isolated transactions, but as an ongoing partnership between patients and their healthcare providers. Section 11. A new era of wellness. As Dr. Sarah embraced this new vision, she felt a renewed sense of purpose and excitement for the future of healthcare. Capitation, she realized, was not a magic bullet, but it held the potential to be a powerful catalyst for change, driving a shift from a reactive, disease-focused system to a proactive, wellness-oriented approach. It was a future where healthcare was no longer viewed as a cost to be contained, but as an investment in human potential. A future where everyone had the opportunity to live healthier, happier, and more fulfilling lives. And Dr. Sarah, armed with her newfound understanding and unwavering commitment to her patients, was ready to be a part of it.